So one is documentation and the other one is communication. So obviously nothing is complete without appropriate documentation. During the PCS, the discussion between me and Dr. Karthik and some of you commented as well. So most of the medical legal problems happen from poor communication and poor documentation. So both are linked. And obviously, you should also document what you are communicating. So especially in terms of a procedure being done or an outcome related discussion, you have to communicate. We often deal with the PPHN, for example, where the babies are very sick. And when it comes to communicating about possible options to transfer, it becomes quite challenging. Communication, one of the key aspects is getting a rapport from the beginning. So suppose you had explained to them about the meconium or the condition, and you can also talk to them about the expected worsening with the high oxygen requirement and things like that. Obviously, not using medical terms as far as possible. In this scenario, you do have to use medical terms, but it becomes easier if from the beginning you have involved them, explain to them. Most of the parents who are educated will understand. Those who are not as educated, you may have to use very simplistic terms in terms of the pressure in the lungs going up or the oxygen. So you may have to just simply say that the lung is not able to oxygenate. Keep it simple and get their trust by giving the full information from the beginning. So open communication, anticipating. So it's very important even at the stage of admission that you can, as we discussed in the management, your saturation levels would be kept a little higher when you expect PPHN. We have the video on PPHN coming up soon. But in terms of management, you have to be clear from the beginning that there is a risk. So the handling of the baby and things are important. So when you communicate with families, openness is important, keeping it simple is important, and updating them at regular intervals. So you may not be the one who is updating the parents all the time. So you have to educate your junior members of the team to be empathic to the family, come to a level where they understand, try to avoid medical terms as far as possible, and document when they're communicating with them, and step-by-step communication. There is nothing, if you put yourself in the parent shoes, you want to know as much information as possible. So there is no time wasted in communicating the information on a regular basis. So the same thing may apply to a premature baby where you're observing the baby, but you think you may need surfactant. So instead of telling them at the time of needing the surfactant that the baby needs an intervention, you can tell them in advance that this is a premature baby. We didn't have time for antenatal steroids. Baby is having this much support now, but if we have worsening, we will consider giving the medicine into the airway. So you can also explain the balloon example of how the surfactant may make it easier for the baby. So again, communication gives them the feel that you are giving them the importance and also gets them involved in the care of the patient. It doesn't make them overly anxious. So most of the parents start getting second opinion or discuss about taking the baby elsewhere if they don't have trust in you. But if you start explaining to them from the beginning, you keep them in the loop. You don't need to give them over information, like, for example, try to explain inotropes or things like that, but you just give them a sequence. You anticipate yourself, you're experienced enough to know that this is likely to be the next stage. Then you look at that. In terms of documentation, how many of you are familiar with the S-bar format? So there are 3 or 4 concepts like this. So privileging is one. Communication, we have the S-bar format, so you can consider looking at its situation, background, assessment, and response or plan. So if you put the notes or the handover notes as well, look at how the nurses are handing over so nothing gets missed out. Dr. Bafi mentioned about documenting the tube position. If any change is done based on the X-ray, unless you document it, the next team may not know. If you are a one-person team, like Dr. Prateen was mentioning that he's managing, and Dr. Nishant as well. So if you are 1 or 2 people managing, that kind of system problems may not happen. But if it's a team, handover becomes very important. If you are in a government hospital with junior doctors and residents, you have to educate them. And Dr. Mala, it needs a lot of effort to change mindset of people. So obviously, one of the things we can do is setting an example. The other thing we can do to improve documentation or the mindset is discussing it on a regular basis. So make them aware of why you are focusing on it. They may not even be aware that there is a medical legal implication. So If you educate them, you can change the mindset. So smaller units, I mean, medical legal problems can come back. And we talked about oxygen, for example, and ROP being litigious. So we never know which family will complain at what time. So always anticipate. Don't assume that you are in a rural center and the parents are not going to sue you. So always take the protection in terms of documentation. And if a baby is sick and you think that you don't have the facility, you have to at least consider and discuss the option to transfer if it's a private center, and then you uh, document that. So that kind of protects you as well, that you have express to them that there is a possible intervention which you can't do, but someone nearby could do. Then leave the choice to them. If they say they can't afford, it's obviously left to them. Yeah. So look at these practices in your unit. I mean, don't assume that what you're doing is the maximum. There is always room for improvement in any aspect. Like that is where quality improvement comes in. You have an eye for catching up what needs to be changed. And that's why in most of the conferences now you'll hear more and more topics discussing quality of care and quality improvement. So it doesn't need to be a laborious process. Anything you do day to day that improves the care of the baby can be quality. It may be something that you want to change the way multiple samples are done superfluously, or you want to minimize intervention in your unit by clustering care. Improvements like that, anything you bring as a change, or IVH prevention bundle, you want to implement the golden hour management, you want to improve. Uh, you start reviewing the antibiotic policy, whether you are unnecessarily using antibiotics or prolonging the use where there is no evidence. So any of these can be a quality improvement project. And when you start looking at these, you obviously start improving your practice. As Dr. Buffy said, when you have audits, for example, you start getting more awareness and there is more pressure on you to do well. And that pressure comes from outside when you have an audit. But if your leadership team and yourselves, they modify the practice, you start setting an example yourself, and that becomes your routine. So you don't need to really look at what the other person is doing. So these aspects are important for our care. And any parent, you can discuss with them to what level they want to know, and you can also judge how they are interacting. So communication part you have to titrate to some extent, but don't hold back information because of your assumption that they won't know. So sometimes the poor patients also understand, and you have to make it simple, but they have a right to know the full information as well. So I think these are very important aspects. And discuss with your team, hand over communication, have role play, have skill drills. The point you made about holding the ET tube with your finger, I mean, the junior staff may not be doing it properly, and when you move the head or something, the tube may dislodge. As we discussed earlier, any intubation is a stressful process, and sometimes you may find it difficult to intubate even. So you need to be careful to secure the tube which is intubated well. Hopefully, I mean, you don't face rough patients, but we hear of violence with patients and everything as well in India. So that's another evidence you have to support that you have actually mentioned it. That's one important point, that when the patients are stressed, they don't register what you're saying in a full way. So that's another thing that you may need to repeat. If they really understand, you may have to go back and repeat it as well. So communication is an art, and that's art which is used less in the Indian scenario, because I worked in both settings, I know, and things are improving, but still you need to change your approach. I mean, maybe when you train in the medical college hospitals, it's too busy for people to stop to communicate. But when you go to the private sector, you know that you do need to communicate. So you may find it suddenly that you have to learn. So better that you start practicing it and you educate the juniors to do it properly from the initial stages as well. So I think if no other
Good evening, sir.
yeah, yeah, please continue,
Good
Dr.
evening, sir.
Parni. Yeah,
Yeah.
please.
Yeah, yeah. Sir, during our daily counseling session, I mean, since I'm in a medical college,
Yes.
daily we counsel the patients and the means parents of the patients. So what we are doing is we have kept a register,
Mhm.
and we explain everything to the parents in their own language, like Hindi or Punjabi. We explain everything. What is the basic problem with the child? Then, if the baby is on ventilator, for how many days the baby will be on the ventilator? What are the problems the baby
Okay.
can face in
Yeah.
future as well? So daily we are doing it in their own simple language, and we are taking the signature of the pair, either mother or father who is coming for the counseling session. So
Yeah.
this is the way we are keeping our record.
And the
And
juniors are watching you as you do it, I think. So
yeah,
that
yeah.
will
So
help them.
the yes, sir. The residents are with us, and daily we are doing as per our unit policy. We are doing the counseling, and the register is maintained, and that register is kept for the medical legal purposes also. In case of some problem occurs, we can always show them that everything was explained. Even the points which we have explained, we do write on the register.
Yes, I think
Like if
the
the
register
patient is
is
on med.
realistic, but the video is a little challenging because how long you will store the video, and you need a little more informed
Uh,
consent for them. Yeah.
Video conferencing, so video counseling, we do it only for the patients who are very high risk or the parents are aggressive. In those cases, we do video conferences that everything has been explained, where we know that might be coming up, cropping up, the problem will be there.
You find
Such cases.
anyone refusing to cooperate with the video recording, or it doesn't come up?
So we are not doing very often, but yes, people are cooperative. I mean, this was just for the own safety we are doing it. Otherwise, everything is written on the register.
Yeah.
Whatever is being told or whatever being consult, and signature, we take the signatures daily on daily basis. Like it's not like one day we have taken regularly basis that they have understood everything.
Yes, I think that makes it a practice as well that you're communicating on a daily basis and documenting. Dr. Momita mentioned similar as well. So these are learning points, and if you think of anything that you want to share with others, please share in the group as well. Thank you for interacting and making it a very fruitful session. And remember, these are important topics. I mean, it's for you to practice as well as disseminate to your team, how the nurses communicate with the parents. And all of you understand what empathy is, isn't it? Empathy is putting yourself in other person's shoe and understand how they feel. So you are thinking like them when they are going through an emotional response. So not just putting your view, but thinking about what they are going through, and having an empathic approach to communication is very important as well. And that's where I said that, I mean, don't be dismissive because a patient you think is not literate enough, or just try to understand what they would like to know if you are in their position, and then communicate like that. So well done to both the presenters today. And I have to